Well, thank
Yeah.
you, everyone, and thank you, Rohini. It's an absolute privilege, and as you said, this has taken a while for us to get together, but I'm really happy that I've been able to, or you've given me the privilege to present on a topic that's very dear to my heart. So clearly, we know the perils of giving online talks, and I'm just hoping my boys essentially stay out. I've locked the door, but I remember this during the lockdown. It was really funny take. But what I wanted to say is really that my conflicts of interest is from the outset. I wanted to say is I do follow a sort of plant-based dietary pattern. Um, and there's for multiple reasons, but more so really after the passing of my dear mum, rather prematurely in her 70s with advanced dementia. And I was on a journey with her for about 10 to 15 years prior to her passing. And she had, as a South Asian, she had the typical sort of metabolic syndrome, type 2 diabetes, coronary disease, and she was treated wonderfully by the NHS. But it really did make me think over that period, and certainly over the last 6 to 7 years, that there are, as physicians and as healthcare providers, that we can do more for our patients. And I hope that basically I'll be able to sort of give you an objective review of the literature surrounding heart failure and nutrition. A sort of disclaimer, but certainly, without the multidisciplinary team, we cannot provide sort of patient-centered care for our patients. And clearly, you know, uh, without people like Becky, who's our registered dietitian at St. George's, this is a partnership, and there clearly I would not call myself an expert, and I always go to someone like Becky to guide me as well. So I'm sort of putting that out there from the outset. So what are the principles of today's presentation? I wanted to quickly go over sort of the terminology and definitions that we use for heart failure, because I think without that, it's going to be harder to then comprehend what I then present later. I want to sort of speak to you about the sort of principles of our management, really the importance of cardiovascular risk in general, um, and then the nuances within that, particularly with regard to assessing the patient with their body mass index, malnutrition, obesity, and how that's slightly different when you're managing it. I'll then go into looking at sort of some of the heart failure healthy dietary patterns that we do have some literature on, and I'll briefly mention just two of the supplements and the data surrounding them. Um, uh, I'll then put a few slides on the guidelines that are out there, although they are sparse, and then a brief look again at the mechanisms. So cardiovascular disease in general encompasses many conditions, including coronary heart disease and stroke. But heart failure is part of that. And we know it's the largest cause of death worldwide. Um, but specifically heart failure, what is it and what do we mean by that? It is a clinical syndrome that's characterized by breathlessness and tiredness and essentially congestion of fluid, either in the lungs or in the legs peripherally. And this is because you've got structural or functional abnormality of your heart pump, which reduces the cardiac output and increases the pressures within the heart chambers, and essentially then either stops the heart from pumping out or having an abnormal filling into the heart. And this was a patient of mine, a South Asian chap in his 40s, who had a large. So this is the four chambers that you see within a heart, and this is the left ventricle, the main pump, the main chamber that pumps blood out to the rest of the heart. And what you can see here is that all of this should be coming in quite nicely, but because of the heart attack, it's essentially not coming in at all. And in fact, there's a big, large clot that's formed here. So clearly this gentleman's insult is because he's had a large heart attack. And so there are many causes, and a heart attack is probably the most commonest reason. We see up to 50 to 60% of the cause for severe heart failure is linked to coronary heart disease. It is a very prevalent condition. There are about over 900,000 people in the UK living with heart failure, and over 200,000 newly diagnosed with heart failure. And as you can imagine, people are being, hospital admissions are going up and up, and this is having a huge burden on the NHS. And it was one of the reasons why we developed the first sort of heart failure unit at St George's to meet this demand. But also prognostically, if you have breast or prostate or colon cancer, you have a better 1-year survival. So it is it does have a huge impact. But it's not all negative. This is positive. We're clearly seeing this is coronary disease or cardiovascular disease, that there is a decline over the last since the 1950s. And you can clearly see that. And that's because we have better technology. Our medicines are better. Patients are undergoing stents if they have a heart attack, bypass surgery. They're being looked after on coronary care units. So all of these things have a huge impact on reducing the mortality for these patients. But interestingly, with heart failure, there appears to be a sort of paradox, really, of our medical success. So as we're seeing that decline in patients having heart attacks, we're seeing an increase in hospitalizations with heart failure. This is the definition. I think this is important. We briefly talk about this, but we always, and you may see these on reports of your patients, or if you are a patient, but we talk about the ejection fraction. And this is, and I'll come into how we calculate that, but essentially if you've got this is your pump function. It's a marker of your pump function. And you'll get a definition of either heart failure reduced ejection fraction or heart failure preserved ejection fraction. You get this sort of mid-range where it's in between. And usually when there's an insult, like we saw with that scan that I showed you earlier, then it's generally a reduced ejection fraction. What you find with preserved is that it's usually a secondary phenomena. You've got it as a consequence of, say, someone with very high blood pressure or obesity. And we calculate the ejection fraction. So as you can see here on the screen, this is a normal heart, very different to the one I showed you earlier. And this left ventricle is coming in very nicely. We then sort of measure what the volume of blood is in the ventricle when it's relaxed and after it's contracted, and then we minus that, and then it gives you as a percentage of, and that's how we calculate the ejection fraction. So there are a multitude of etiologies, and certainly as a heart failure physician, when I see a new patient, I need to be going through these in my mind. As I said earlier, that coronary disease is the commonest reason, but there are other causes, including hypertension, and we have to sort of work through that. And it can either be, as I said, you look at this to see whether the pump function is significantly reduced, or is it actually normal, but you still have a very stiff heart pump that essentially then means that your ejection fraction is normal, but you still have heart failure symptoms. So preserved ejection fraction tends to be associated with other comorbidities. And so the key for managing these patients is to address those comorbidities, such as high blood pressure, diabetes, CKD, and anemia. So this is data from St George's, about 1,400 patients in our clinic. And you can see that ischemic heart disease is our commonest cause, and actually the cause that you have that can also impact on your prognosis, and how, clearly if you've got a disease that we can identify a cause, such as alcohol, for example, where at least 30% of our patients who have excess alcohol intake will may develop heart failure. But if you stop and abstain from alcohol, then potentially there's recovery. So that will have an impact on your long-term outcome. But also, I think it's quite interesting, especially in South London, that we look at it from an ethnic point of view as well. As you can see from this, it's a busy slide, but what I wanted to say is, for example, if you're South Asian, you will generally, if you have heart failure, will have what we call coronary heart disease related heart failure, or an ischemic cardiomyopathy. But actually what we see within our Afro-Caribbean population is very often they present very young, uncontrolled hypertension as a driver for their heart failure. And, you know, it's sort of important, I mean, especially that we look at that from a lifestyle point of view when we're managing our patients, and looking at the cultural nuances when you're assessing, you know, is this something to do, you know, with the social determinants of disease, making sure that they understand their condition appropriately, making sure that their environment is appropriate. We know that there are food deserts out there, there's food insecurity. So all of that needs to be taken into account, especially when you're making that assessment of our patients. Now, from a pathophysiological point of view, you get that insult to the heart, like a heart attack, and then it starts to adversely remodel over time. And over months, you can then start to get this sort of ballooning or enlargement of the heart. And the same can happen, say, with high blood pressure, where you generally will get this thickening of the heart muscle. But eventually, if you had it uncontrolled, then again, you'll get this insult. I'll leave that. So the reason I'm talking about this neurohormonal aspect of this, because I will talk about some of the aspects of weight loss and how it affects some of these pathways later. But what happens is you have this compensatory mechanism when your heart is not pumping, your blood pressure drops, your cardiac output drops, so the body has to compensate, and it compensates through mechanisms like the renin-angiotensin system to increase your blood pressure, to cause vasoconstriction of your blood vessels. But actually, over time, that compensatory mechanism becomes detrimental, leading to that congestion of water and salt, and stimulation of the sympathetic drive. Now, the body does try through this system, the natriuretic peptide system, to counter that. And we essentially, with our therapies, try and address these pathways to try and treat our patients. And we have actually wonderful medication, especially for patients with reduced ejection fraction heart failure. And it is the cornerstone of how we treat our patients. The data is showing, you know, huge prognostic benefit, including device therapy. And so it is really important that I emphasize early on that medication is evidence-based and is really important. With heart failure preserved ejection fraction, it's less so. We don't really have any evidence-based data around that, but the key for that is to look at those comorbidities that I was talking about, like the blood pressure, like the diabetes, like coronary disease, and address those and treat the patients. So that's the sort of the primer with regard to heart failure. I think the key, what I wanted to mention here, is that obviously we've got proven pharmacological and device therapy for our patients, but over and above that, how does diet and lifestyle impact? And this was a fascinating study of over 31,000 patients from 40 countries that were taken from 2 large pharmacological trials. And they looked at lifestyle, but also looked at nutrition. And they used the Alternative Healthy Eating Index as a marker. And we know that that is plant predominant. I think 7 out of the 9 in this current study were plant-based, high fiber, low saturated fat, low sort of sugar. And what they showed was that if you follow a healthy lifestyle, including healthy nutrition that's plant-based, that you see a 28% reduction in heart failure incidence. So this is over and above. This is as an adjunct to medical therapy. and it shows how important it is for our patients. Um, for all talks with regard to cardiovascular disease, and particularly with lifestyle, it is so important that we talk about cardiovascular risk, and that's the same even for heart failure risk as well, because we know, as I've alluded to, that the commonest cause is coronary disease. Probably the second commonest is hypertension. You know, if you can address these, then certainly from a primary prevention perspective, you're going to prevent patients from getting heart failure. But if you have heart failure, then addressing those, for example, with coronary disease, we know that reducing your sort of saturated fat, reducing your cholesterol levels and LDL cholesterol, the bad cholesterol, then that's going to have an impact on developing heart disease or progressing. So, you know, this is probably one of the most important slides in terms of risk management, and it has to be sort of almost instrumental in how we look at our patients in the clinic setting. But the other thing with heart failure is that it's not usually just heart failure. You know, almost 98% of our patients will have at least one other comorbidity, but often it's multiple comorbidities. And diabetes, at least a third of our patients have diabetes. Almost a half, I was speaking to one of my renal colleagues, almost a half of our patients often will have CKD, chronic kidney disease. So looking at that aspect, looking at it in a holistic way is so important. I think a lot of my work has already been done, and I could probably stop my talk at this point, and I would certainly recommend going back and having a look at these areas, conditions and comorbidities, and how lifestyle has a huge impact, again, for these patients with these conditions. So in terms of nutritional management principles and how I sort of look at it, I think the first thing to say is you need to assess what stage is the patient that we're seeing. You know, if they're at the pre-heart failure stage, that's the primary prevention aspect of it. You know, can we prevent them from developing heart failure? That you know, patients coming with a heart attack who've got normal heart function or reduced function, but you know, if we get in there aggressively with both medication and lifestyle intervention, can we stop them from going down this trajectory? This stage, stage B and stage C of heart failure, is where you either have symptoms, you certainly have heart failure, but you have symptoms or you don't have symptoms. And a very important group that we should be sort of, again, aggressively assessing them, making sure that we can stop them from going into the final stage of heart failure, which is often sort of end stage, end of life care. Now, sometimes patients can present at this stage if they're sort of late presenting. So it's very important to assess where they are on this trajectory. The other area, as I said at the beginning, is to look at their body mass index. Where are they? Often when they're at that end stage D, they're usually in the low BMI, low body mass index area. The nuances of managing that from a nutritional perspective is very different. And you know, it's certainly outside of my sort of expertise, and really the registered dietitians have a major role in that group. A lot of the emphasis of my talk will be in this high BMI, normal body mass index group. We know that obesity, malnutrition share lots of common mechanisms. You know, it's an imbalance between your anabolic and catabolic state. It's a pro-inflammatory state, and often they share mechanisms that are very similar with the pathophysiology of heart failure. Other aspects when you're looking at a patient is to look, as I said earlier, looking at the cause. You know, is it alcohol? You know, why are they presenting? Looking at those risk factors again, looking at those comorbidities. We'll talk a bit about fluid management. You know, they're congested. Is there anything we can do to try and prevent that? And clearly, preventing patients from developing malnutrition is important, because we know prognosis is poor. So I'm just going to talk about body mass index. We know that if you have a low body mass index, less than 20, that you can have a 2 to 10-fold increase in death. It's important to realize that when you're assessing a patient, they're often fluid overloaded with heart failure, And it's important that once their fluid has been taken off, that then you assess their weight, because often a congested, fluid overloaded patient may be looked upon as normal BMI, but actually they're malnourished. The prevalence is variable depending on the tool that we use, but we often see it particularly in patients coming into hospital with acute heart failure. This is just a mention. It's worth having a look at this review. This is Becky Jones from St George's, our registered dietitian, just talking about the different screening tools and what we use at St George's to identify these patients early on during their admission. Clearly, malnutrition is common with most chronic diseases, particularly in heart failure. They will have a reduced appetite. They develop fluid in the abdomen. They get fluid in the liver. That causes them to reduce their appetite. Sometimes the medications can make changes to their taste. Breathing, the acuteness of having to be really breathless is a high energy state. And so all of these can be linked to their malnutrition. The other aspect is cardiac cachexia, often seen at that end stage of the disease. As we know, it's a complex metabolic wasting syndrome characterized by sort of weight loss, the anorexia, inflammation, and abnormal biochemistry. And we know that it's prognostically bad. 15% of our heart patients have it, and it's often very common to prognostically with a lot of other cancers. In terms of assessing that, again, as I said, it's probably outside of my expert area, but you often have to look at it from an anti-inflammatory perspective, or trying to promote an anti-inflammatory diet, maybe looking at sort of the omega-3, also really important exercise and resistance-based activity to increase muscle mass. And certainly the Academy of Nutrition and Dietetics have suggested that, particularly in this cohort, that we should be thinking about providing protein levels at 1.1 gram per day per kilogram, as opposed to the recommended 0.8 grams per day per kilogram. So what about increased BMI and heart failure? Obesity, we know, is a major independent risk factor for heart failure, as it is for other cardiovascular diseases. And so primary prevention there's a lot of data there. But secondary prevention, if you've got established heart failure, the data is a sort of evidence-free zone. But I will try my best to have a look at some of the science behind the potential of secondary prevention. This is looking at the Framingham study, which showed a dose-dependent relationship to the risk of heart failure in primary prevention. So every kilogram per meter squared increase in your body mass increased your risk of heart failure, particularly in heart failure preserved ejection fraction. As you can imagine, as I said, that's often a secondary phenomena, or as opposed to reduced ejection fraction. This is a really interesting paper looking at the impact of obesity on very similar neurohormonal pathways that we see within heart failure. So we know that leptin is increased by the adipocytes. It gets secreted, goes to the hypothalamus, and it makes you feel full. But it can also have an impact on stimulating some of those neurohormones that I was talking about, like aldosterone or the renal angiotensin system. And so all of these are increased during obesity, separate to actual heart failure. We know it's also a pro-inflammatory state, which again potentiates or could worsen someone with heart failure. We also know that the drugs that I've discussed can affect and reduce aldosterone, your leptin levels, your neprilysin. But what about weight loss? Can that have an effect as well on some of these pathways? And there are some interesting studies, very small, but even a 5% reduction in weight can have an effect on reducing aspects of your renin-angiotensin system, even neprilysin. Neprilysin is an enzyme that breaks down those good natriuretic peptides. So by reducing your neprilysin levels, you then potentiate those beneficial compounds. But I think no discussion, if you ask an average cardiologist um, how much effort they spend on helping their patients lose weight, most would often say or admit very little. And in defense, they could point to this concept of the obesity paradox, where, particularly from observational studies, you can see that if you are higher BMI, your prognosis is much better than if you are leaner. And it is an interesting thing that's seen in most chronic diseases. But actually, I would, if you look at some of the recent larger studies, this is a huge paradigm heart failure trial where they then wanted to look, and they adjusted for prognostic variables. They were able to show actually that the paradox isn't really there. You do get a sort of U-shape. So clearly, when you are very lean, which could represent sort of end-stage disease, your prognosis is not great. But also when you're morbidly obese, your prognosis is also not great. Often suggestions are that if you are obese, then or higher BMI, you're younger, you have an earlier diagnosis, you start medical therapy a bit sooner. That impacts on a favorable point of view from your prognosis. And as I said, if you have a lower BMI, it may represent sort of that stage D, that end stage, cachexia, worse prognosis. But this is really interesting, actually, and some people have suggested we should be calling it a lean paradox. But in this study of 70 patients with heart failure, they combine the assessment of the body mass index with the arm circumference and improve. And what they showed was that if you and the arm circumference is a marker of your muscle mass, but if you basically have low BMI but high muscle mass, then you're going to have the same prognosis as someone in the high BMI bracket. But if you have low BMI with a low arm circumference, then your mortality is much higher. And the same has also been shown with cardiorespiratory fitness as well. So clearly there's more modification of this paradox. And that's why I think it's so important that exercise and resistance training is part of this treatment that patients get from a lifestyle perspective. So really, if you are overweight, we know that controlling your comorbidities will have a huge impact in preventing heart failure. We know you have a better quality of life, exercise capacity if you can reduce your weight. Another important point is that often if we have an overweight patient who would fulfill criteria for cardiac transplantation, then we would often have to advise them to lose weight, which would then allow them to then be considered for transplantation, often a cutoff of 30 BMI. And we talked about the impact that weight reduction has on those neurohormonal pathways. But interestingly, there's some data to say that it has also an impact in improving your cardiac function, such as the LV ejection fraction. So let's now, talk about some of these heart failure healthy dietary patterns. And I'm going to focus on three that has some evidence. I'm not going to go into them because I'm sure there have been other talks looking at them, but clearly the DASH diet was designed for blood pressure lowering. Yeah, it was essentially initiated as a sort of vegetarian diet, but was then allowed to include animal products to make it more palatable. We know it's predominantly plant predominant, but with low levels of fish and poultry and low-fat dairy, with a real minimization of red meat, processed foods, and sugar. This is a sort of primary prevention look at the DASH, and certainly if you follow a DASH-like diet, there is a dose-dependent association with significant reductions in cardiovascular disease, particularly with heart failure reduction in a group of patients who were at risk but did not have heart failure. There are small studies, non-blinded, non-randomized, controlled, looking at the effects of the DASH intervention. There's studies in the preserved ejection fraction group and also in the reduced ejection fraction group. And overall, they were showing, in these sort of very small pilot studies, improved exercise capacity, better quality of life, BNP reduction. Now, BNP is a protein, that beta natriuretic peptide that I was mentioning, that we use as a marker of severity of heart failure. It links to prognosis. So there's a reduction in the BNP and improved other markers of cardiac function, like the LV ejection fraction. Small numbers, but clearly pointed towards a positive aspect of the DASH. This was a multi-center randomized single-blind controlled trial in 66 patients who admitted with heart failure, sent home with home-delivered program for 4 weeks. And although not significant, the outcome did show a trend to reduce hospital readmissions. What about the Mediterranean diet? Again, I'm not going to focus too much on the components, but again, a predominantly plant-based nutrition. Clearly, we have robust data, certainly in the primary prevention field with the PREDIMED study in over 7,000 patients, followed up to 5 years nearly, that there was a reduction in the composite cardiovascular, particularly with stroke, by 30%. Very low incidence of heart failure in this group. We also have the Leon Heart study. This is patients who've had a heart attack. And there was clearly benefit in those patients following the Mediterranean style diet. But what about within heart failure? If you looked at this interesting systematic review meta-analysis, particularly they focused on the Leon study, they were able to show a significant reduction in the incidence of developing heart failure. This is from the PREDIMED. Although there was no link with heart failure in the study outcomes, they were able to show that those following the Mediterranean diet tended to have lower levels of the BNP levels, which again would point to a reduced risk of developing heart failure. This is for a study taken from Spain, I think 7 accident emergency departments, and it was sort of an association study where they looked at admissions, and the greater your adherence to the Mediterranean diet, the less heart failure rehospitalizations you had within the year. Similar to the Leon study, this looked at patients and their adherence in patients who came in with unstable angina or heart attacks, single center study. But again, they showed that actually if you followed greater adherence to the Mediterranean diet, you had a less likelihood of developing poor heart function. There was better remodeling of your heart, and event rates were certainly much less over a 2-year follow-up. What about if you sort of comparing the DASH to the Mediterranean? This study from review from the Women's Health Initiative with heart failure over a sort of 5-year period revealed that participants with a higher DASH score were associated with significant but modestly lower mortality rates. It didn't reach significance, but you did see mortality reduction with the Mediterranean diet scores as well. So what about a whole food plant-based dietary pattern? This is Kyla Lara's work from Mount Sinai, where they looked at the National Prospective Cohort Study, which was looking at stroke risk factors and incidence. But actually what they did find was that higher adherence to plant-based diet was associated with a 41% lower risk of heart failure hospitalization. And if you did follow a more southern-based diet of more processed, fried foods with sugar sweetened beverages, your risk of heart failure was incredible, 72% higher risk of heart failure hospitalization. And again, very similar data was picked up from the Women's Health Initiative, saying the more plant-based you were, the lower your risk of heart failure. And there have been quite a few, I could find 3 or 4 case reports in the literature from Robert Oswald at Montefiore in New York and Baxter Montgomery in Texas, looking at actually the impact of going whole food plant-based, and in some cases quite significant improvement in cardiac function despite no real change in heart failure medical therapy. So, really important, although case reports, they do give us some clues to the benefits here. I'd like to thank Shireen for this slide. In some ways, it was adapted from Conor Curley's review article, which I would highly recommend people go and have a read. But clearly, I'm very keen that we follow more dietary patterns. But if you looked at dietary components, the increased incidence is seen with that sort of southern pattern. There's a meta-analysis looking at greater than 6 eggs a week, worse outcome. Interestingly, looking at fish, non-fried fish versus fried fish was increased incidence. If it's non-fried, the data is equivocal. So I'm near the end. I just wanted to quickly look at supplements. I'm going to briefly talk about coenzyme Q10 and omega-3. Coenzyme Q10 is an essential cofactor for energy production. It's a powerful antioxidant. And we also know that there are low levels of coenzyme Q10 within the myocardium of patients with heart failure. In this study, the Q-Symbio trial was a randomized double-blind trial, which did show, actually, after about 2 years, there was a 50% reduction in the sort of major adverse cardiac events. There was also improvement in symptoms for these patients. It's a very small study, and it's not really been adopted in the guidelines, but clearly something to be aware of. Omega-3 polyunsaturated fatty acids, essential fats that we all need. We can't synthesize it ourselves. There's a lot of debate in the world of cardiovascular disease. We know that you can get dietary sources of the short chain ALA from flax seeds and chia seeds that are then converted to EPA and DHA. And certainly, if you're following a whole food plant-based nutrition and you're reducing your levels of the omega-6, because we know that can impact on the conversion, then you should be getting adequate levels. We know that it has an anti-inflammatory effect. It has an anti-hypertensive effect. We know at higher doses it can reduce your triglycerides, but also in heart failure, it can potentially increase your LV heart function. And the guidelines suggest that it potentially or may be used in patients with reduced ejection fraction. And that's predominantly based on this trial called the GISI heart failure trial. Large study, over 6,000 patients with both heart failure preserved and reduced ejection fraction who were on 840 milligrams per day of EPA and DHA. And they were able to show a 9% reduction in mortality with also an increase in LV ejection fraction. Two new, so there's 2 meta-analysis. There's one from 2016, again inconsistent in conclusions for omega-3, but again an increase in LV ejection fraction, particularly in the dilated cardiomyopathy groups. And this new trial, meta-analysis just out in March this year, again showed the benefit from an anti-inflammatory perspective, but they were also able to show a sort of dose duration dependent effect on the LV ejection fraction if you're taking doses of higher than 600 milligrams. And clearly anything sort of 1 gram and above there was a greater benefit on LV ejection fraction, again in the dilated cardiomyopathy group. These are groups not insulted with coronary disease. So international guidelines, common dietary advice is salt and fluid restriction. Evidence is very conflicting. In fact, there's no real evidence for salt restriction in terms of prognosis, hospital readmission. We tend to reserve it for patients who are hospitalized with fluid overload or resistant to diuretic therapy. This is a very busy slide, but well worth a read and going back. But the data, even though the evidence is not great, most of the guideline committees, whether they're in America or in Europe, suggest up to 2 to 3 grams salt restriction. The Europeans take it up to 5 to 6 grams per day. Fluid, again, it's more if you've got hyponatremia or you've diuretic resistant, then we tend to ask them to fluid restrict 1.5 to 2 liters. We've talked about there was no, most of these other supplements are no recommendation. We've got coenzyme Q10, again, not recommended. And we've talked about cachexia and obesity. I just want to point you to this review article, fantastic paper, which was where they got these world experts in nutrition, including people like Walter Willett, for a 3-day consensus in Geneva. And what they concluded was, on the basis of the current evidence, the traditional Mediterranean diet, including plant foods, should be the ones that we should be recommending for our patients. And that's what they showed here. Mechanisms, because of time, I'll probably not go into these too high, but we know we've talked about risk factors, clearly a major contributor. Got TMAO, which has often been discussed with coronary disease, but has also links with heart failure. Your microbiome, there's data on the gut microbiome axis. There's the anti-inflammatory aspect of heart failure nutrition, and also quite an interesting link with nitrates and nitric oxide, which causes vasodilation and helps to take the load off the heart pump. This is the gut hypothesis of heart failure, just to show about the TMAO, which is often linked with sort of cheese and red meats and processed meats, which the gut flora then convert to TMA in the liver. It gets converted to TMAO, and that potentially can have an effect on your cardiorenal syndrome, so coronary thrombosis, heart failure. And there's a link with, we know that plant-based diets can reduce your TMAO levels, and there's clearly an increase. The higher your levels, the worse your heart failure is. Inflammation, I won't go into this too deeply, but clearly validated and linked with heart failure. And we know that following heart failure healthy nutrition, that you can actually have a huge impact on reducing your inflammatory load and your overall outlook. Nitrates, the green leafy vegetables, we know that there's an enterosalivary pathway that increases your nitrate levels. And this very interesting Danish diet cancer study looked at over 50,000 patients, and a moderate intake of vegetable nitrate, we're talking about 1 cup of green leafy vegetables, was associated with a 15% lower risk of developing heart failure. And again, beetroot juice has also been implicated in and just been shown, particularly with exercise capacity in patients with heart failure, preserved ejection fraction. So finally, I just wanted to say, look, the biggest challenge, I think, is as doctors and physicians, we often overlook what are the challenges facing our patients. And often when you ask them, it's actually that they're unable to do their exercise, they're feeling down, feeling sad and depressed. And that's why I think it's so important that we not only look at it from a lifestyle, looking at nutrition, but you look at physical exercise, which has huge benefits in our patients, even survival benefits in patients with reduced ejection fraction, and clearly mind and body techniques are also very important when we're assessing our patients. I just wanted to put this out there that I think a lot of the data I've shown are small studies. There's clearly a need for more randomized control studies and in heart failure. What I've got here is the survival curve of a patient with current medication is great. If you don't have it, this blue line, your prognosis is worse with medication. Can you imagine what it would do if we could get this survival curve up here, if we could introduce really important nutrition, lifestyle and exercise and mind-body assessments. So finally, to summarize, we've talked about all these impacts that can cause heart failure, the importance of lifestyle, following a healthy diet, exercise, mind-body training, and this is taken from the American College of Cardiology Nutrition Lifestyle Committee consensus, and they have suggested that we should be following a more plant-predominant diet, low in sodium, high in potassium, with lots of green leafy vegetables. So thank you.
That was brilliant. Thank you so much, Nesan. You were so incredibly thorough that quite a few of the questions have already been answered, but I do have some lined up. I think we have just under 10 minutes. I think your video's disappeared. Are you?
No.
Wonderful. So firstly, I'd just like to ask how you became interested in this area personally. I know you follow a plant-based diet, and I was wondering if you could just share a little bit about your personal journey. I think it's always nice for people listening to hear a bit about that.
Yeah, so I think, as I mentioned at the beginning, I think, Rohini, I had been on this journey with my mum for about 10, 15 years and had just seen, and it's not only my mum, being South Asian, I have lots of family and also patients that I see that as physicians in the modern day clinical practice, we're very good at treating diseases. But really, I was getting quite frustrated that we were unable to sort of either prevent or look at other areas that we could have a huge benefit. And so I started sort of delving into this maybe 10 years ago, but it wasn't only, that journey sometimes for people is an individual. It took me 2-3 years to look at the science. I was blown away by some of that early science, from the Ornish and Esseltine data. And then I just started to look at it further and realized that there was a huge community out there looking at this. And just then seeing the impact that it has on our patients, that's sort of the background of how I got into it.
No, that's great to know. So you probably get asked this question quite a lot, but I'm going to ask it. What are your views on extra virgin olive oil and oils in general for patients with heart failure, as well as other healthy individuals? Do you have any thoughts on that?
Yeah, I think obviously when you look at the original Ornish and Esseltine data, they were obviously pioneers of the no oil or low oil camp, and unfortunately within cardiovascular disease itself and lifestyle and particularly nutrition, there are different camps. I actually don't fit a camp. What I think is that we can't ignore the evidence base behind extra virgin olive oil. We can't ignore the PREDIMED study, the Leon Heart study, David Katz's data looking at, so a lot of the premise behind the early low oil data was looking at sort of endothelial function. What I saw a very interesting Katz paper showing that actually it's the quality of that oil that has an impact. So if it's full of polyphenols and good, and they compared that to just refined olive oil, and there was a huge difference. So I do think that we have to look at the science, and the science would suggest that we know that if you replace saturated fat with monounsaturated fat or polyunsaturated fat, you do far better. So I suppose that to counter that, we know that oil is high calorific. 5 spoons is equivalent to maybe 600 calories. And if you are thinking of weight reduction or reducing your sort of metabolic risk, then actually you want to reduce that. And so I think it's an individual choice. Clearly, you could argue that if you have quite significant coronary disease, you may want to reduce it. But I think we have to just follow the science at the moment.
No, I really appreciate that nuanced answer. So this is a more specific question. Should patients with fluid overload eat more diuretic food groups, such as celery, watermelon, these kinds of foods?
Yeah, it's to be honest, I don't have an answer to that because I don't think we have the sort of the data or this, I haven't seen any studies looking at that. But clearly, I suppose it's a bit like caffeine, which also can act as a diuretic. It's not something that I certainly won't advise patients who are sort of being fluid restricted, but it would be an interesting thing to look at and see if there is anything on there in the literature.
And I suppose these foods are healthy anyway, generally.
Yeah,
So
exactly.
yeah, watermelon, celery, things like that. Why not? So there's another question about CoQ10 supplementation. Are there any risks with excess CoQ10 supplementation? Is it a supplement where the dose needs to be carefully controlled? And if so, what is the amount you generally recommend for people?
Yeah, so I think that obviously the guidelines at the moment don't recommend it, and that's because although there was the Q Symbio trial, it was only 400 plus patients. So at the moment, evidence-based wise, it's still not being recommended. If you looked at that specific trial, I think it was 100 milligrams TDS or 3 times a day they were using. The caution with coenzyme Q10 is that it can have interaction with particularly heart-related medication. And so if you're on things like warfarin, blood thinner, or beta blockers, then you have to be a bit more careful. And that's why, I'm a bit wary. So actually, to be honest with you, I haven't yet used it in my cohort of patients. But clearly, I think it's important to mention it because it's there in the literature.
Okay, no, that's super. So one of the questions that comes up sometimes is around coffee. What are your views on coffee? Again, I know that there are individual variations, but in this particular context, what are your thoughts about the inclusion of coffee?
Yeah, I think, everything, putting aside the other aspects of, if we're looking at it from a lifestyle point of view and sleep and, half-lives and making sure you're not having a cup maybe after midday based on half-life. I think from a cardiovascular point of view, you do get sort of both positive data with coffee, but particularly with filtered coffee, because I think there is some data to suggest that some of the properties of unfiltered coffee can increase your LDL cholesterol, and so potentially could then increase your risk of developing atherosclerosis. But I think if you're having filtered coffee, then the data is, if anything, probably a bit positive.
Great, and ideally have it either black or with a plant-based milk like
Of
soy.
course. Yeah, yeah.
Wonderful. So should the aim in coronary heart disease be plaque regression? Is that what cardiologists, is that what we should be aiming for? Is that your main focus?
No, I think there's 2 ways of looking. I always tell my patients, even from a heart pump point of view, is that you may have the disease process there, but the number one thing is to stop progression. Okay, so I think that's really important because if we could, or not at least try and reduce that chances of it getting worse, going down a different trajectory. But the issue of reversal, Rohini, as I'm sure you know, again, it's a bit like the no oil debate. It's become a bit of a camp thing within cardiovascular disease. We know that there's some wonderful sort of case reports out there, and certainly from Esseltine's data, where you saw reversal of almost coronary disease there. Some criticism has been about the techniques like the old style angiograms looking at that and suggesting that we should be looking at it with ultrasound guided, but we need studies to show that. What we do know is that with the high dose statin trials, they did show that there was some regression in the plaque. But to be honest, for me, it's about preventing whether you've got disease established or not. If I can reduce that LDL cholesterol to as low as we can, below 1.8, then your chances in the developing coronary disease going forward is much, much less. So that's the way I would look at it.
No, it's super helpful. And I think for anyone who's listening, obviously at PBHP, we do focus a lot on prevention. So having a look at some of the fact sheets that we have, the 21-day challenge, all of that is going to be really helpful if you are concerned about this topic as well, which I think we all should be. This should be top of mind for everyone. So last question, I'm going to launch a little poll. I know that we've just gone over time to get everyone's feedback on the session, which was so thorough. I really, in terms of the questions, I can see that not that many people needed to ask that much because you covered so many bases. But one final question about COVID and how that has affected, how that's affected, the heart risks and what you've seen perhaps in your patients, and if anything that would be helpful for our listeners.
Yeah, so I mean, clearly the big thing was the sort of cardiometabolic risk and your risk of getting more severe forms of the COVID. I think that was highlighted very early on in the pandemic, and we realized that actually if you had a lot of these risk factors, then you would have more severe disease. And I think that is certainly what COVID has highlighted for me. But also we were seeing quite early on patients coming in with heart attacks. So because of that sort of pro-inflammatory state, but also interestingly, one of the impacts of COVID is that a lot of my patients, particularly the heart failure patients, were not coming in during that period. And that has had a huge impact. And we are concerned that now that we're sort of opening up, that the impact that that's going to have on our patients that haven't been seeking sort of medical input during that period of time. And certainly in our 2-week, we run heart failure 2-week clinics, we're seeing sort of patients coming who may have been sort of, if they'd been seen earlier on in the pandemic face to face, we would have been able to get in earlier to try and help them. So I think that is an unfortunate impact that we're going to see of COVID going forward. Fortunately, during the last year, we continued to do face-to-face clinics. So, I think certainly at St. George's, I'm hoping that that we can continue to keep our patients safe.
Thank you for that. No, this has been incredibly helpful. I feel like there's generally, quite a lot of discussion about coronary heart disease or heart attacks, but we don't hear as much about heart failure. So I personally learned a huge amount from the webinar, and thank you so much for making time. I know you're incredibly busy with so many different projects, and of course you're on the University of Winchester nutrition course that Shireen and Layla run as well. So if anyone is interested in that, then we have details on our website. But thank you everyone for joining. I know that we have some new faces as well tonight, so do go and check out plantbasedhealthprofessionals.com. We would love to see you at future webinars and events as well. And there's been some lovely comments as well, which I will definitely share with you as well, Nesan. But thank you again, and good night everyone, and thank you for joining.
Thank you everyone.